All right, well, welcome back to Ultrasound Grand Rounds again this week. We have been progressing over the course of this fall with some various different topics. We're kind of do some basic topics. We went to the basic fast. We're doing the basic cardiac the last couple weeks, and today we're going to pivot into some abdominal stuff. So we're going to start a little bit of a series on gallbladder. So the first one today is going to be the normal gallbladder, and then the next time we meet, we're going to talk about the abnormal gallbladder. And it seems fitting that we kind of change topics. I know the weather here in Cleveland's kind of changing a little bit. We got our first snow of the year. And so with that, we're just going to kind of change and pivot to kind of some new topics and talk about new areas here in Ultrasound Grand Rounds this fall. So without saying more, let's dive on in. We'll put up the presentation here for basic gallbladder ultrasound. And like I said, today is going to be just the normal gallbladder. We're going to talk about how to scan the normal gallbladder. And then in the next time, we'll add in a little bit more of the how do you see the pathology and things like that. So gallbladder ultrasound. So as I always like to do, let's start us off with just a little bit of a case, right? Just kind of something to warm up the mind, get ourselves kind of thinking down the right pathway here. So gallbladder ultrasound, imagine yourself in the emergency department. We're seeing patients, it's a busy clinical shift. You're over in, the fast track area, you're over in the main area. It doesn't really matter. But you have a 35-year-old female who presents, that comes in from home by EMS, whatever, presenting with severe right upper quadrant pain, right? And so that is, kind of an interesting way of getting into kind of a whole bunch of different things, right? That opens up a very different, broad differential diagnosis. And so I think one of the first things we need to think about, and kind of as I have residents and medical students presenting to me, I have this patient with right upper quadrant pain. They kind of flesh out the story a little bit. Here's what's going on. When I push, it hurts, maybe some nausea, vomiting, things like that. The first question is like, hey, what do you think is going on? And then, what do you want to do? And so kind of going through there, like, what is your next step, right? We have this patient who's in front of us, right upper quadrant ultrasound, or right upper quadrant pain, hopefully over the course of today, and I just let the cat out of the bag with ultrasound, right? We're going to talk a little bit about what are our next steps in the evaluation of this patient so we can get to then the management as we understand kind of what's going on wrong. But before we get to the thing to do, right? And I always like to stop and slow down our new trainees and say, okay, you have a whole bunch of great things that you're shotgunning to me as, items that you want to test or items you want to do. What is your differential diagnosis, right? What are the list of things that could be possibly going on with this particular patient in front of you? Because that is going to be the biggest thing that helps us decide what next steps we're going to take, what labs we're going to order, what imaging studies we're going to order, what medicines we're going to give, and what our ultimate disposition is going to be. And so as we start thinking about this, we have a 35-year-old female presents with right upper quadrant pain, tender to palpation, it's going to have some nausea, vomiting. It's focused in a way. It gives us kind of a place to focus in on. However, it by itself is a little bit non-specific. And I had this thought, years and years ago when I was kind of in training that as we take a big subject, right? So patient presents to the emergency department. We're getting some information and we narrow the focus, right? We narrow that focus of what's going on to the right upper quadrant, right? But when you narrow it to the right upper quadrant, that in and of itself kind of opens up an inverse kind of funnel. And I think of it kind of in the formation or the shape of an hourglass, right? You narrow it down to that little narrow point to get to the right upper quadrant pain, but then that itself opens up to that big, the bottom part where there's a lot of things underneath that we can kind of branch out and talk about in that right upper quadrant pain. So getting back a little bit kind of down to earth here, when we say right upper quadrant pain, it could be a whole number of things, right? When we talk, we can think about the biliary system, right? That's kind of where we're going to go today. But the gallbladder, right? So could it be, cholelithiasis? Could it be cholecystitis? Could be a cholangitis, right? There's a whole bunch of different things in that gallbladder. We narrow it down to the gallbladder, we can open it back up again, right? If we switch over to the liver, right? There's a whole bunch of stuff that can cause pain in the liver. All your hepatidities, A, B, C, D, whatever. Does a patient have like some liver pathology like cirrhosis that's causing something else, right? That's causing pain in the right upper quadrant. If you go a little bit more midline, or perhaps you're feeling it on the right, you have pancreas, right? Pancreatitis. Do they have some, inflammation? They have some, cyst or mass or whatever. They have something in that area. And then if we get kind of out of the whole liver gallbladder complex, right? What else lives near there? The kidneys, right? Could it be something renal? Could it be a renal stone? Could it be pyelo? Could it be some obstructive process? There's a whole lot of stuff that, is in the neighborhood that can feel pain in the right upper quadrant. And finally, you can't forget the ubiquitous GI system. So is this something like a gastritis? Is it duodenitis? Is there any of the, random esoteric GI diagnoses that that can afflict our patients. And so as we kind of start thinking through this patient with right upper quadrant pain, we start developing a very robust list of things that we can be compartmentalized into organ systems, but still each organ system has its own list of things that could be causing some pain in there. And so at some point, they say 85% of all diagnoses are made with the clinical history and the physical exam. And that's true, but a lot of things, that history and physical exam gets you to a certain point, right? That's a test in and of itself, but the test characteristics are oftentimes vague enough that then we need to supplement that with some other tests, like actual literal tests that we can do. And so in our context, we're then going to do some labs, right? We're going to do a CBC and we're going to look at a BMP. We want to look at their cell count, see if there's any signs of inflammation, in their cell counts. So we want to see if there's, a hemoglobin drop, if they have like a GI bleed or something. We want to look and see what their creatinine is to see if their kidneys are working okay. We want to look at their LFTs to see if there's any obstructive process in their bilies or if there's any inflammatory process in their AST and ALT. We want to look at the lipase to see if there's anything that's going on with the pancreas, right? This is all giving us a robust picture of kind of what's happening in these different organ systems, right? And the UA to see if there's any blood or if there's any inflammation, to kind of look at all these different things and see if we can take that history and exam that we've narrowed down to these 4 different systems, and if we can narrow that further into a particular system and a particular kind of vague entity in that system, and then at the end of the day in the right upper quadrant, the thing that we're going to probably end up doing a lot of is just imaging, right? And we got to look inside, right? Peel the skin back, look into the abdomen, and see what exactly is going on inside this patient that's causing this right upper quadrant pain. So that's kind of the philosophical perspective of how we're going to get from like the presentation all the way down to the workup, right? And that leads us into the rest of the talk, where today what I want to do is, as we think about this right upper quadrant pain, right, I want us to think a little bit more about the anatomy and physiology, specifically of the gallbladder, right? Because this is where we're going to, one of the imaging tests that we're going to hit at, and I'll look at some epidemiology in just a sec to show kind of why we want to look at the gallbladder specifically, right? So we want to look at the anatomy and physiology of the normal gallbladder today, right? We wanted to look at the sonographic or the ultrasound appearance of that normal gallbladder. And finally, we want to talk about some pearls and pitfalls as we scan this gallbladder to see, what's going on, things that could kind of trip us up or get us in trouble. And all this is going to set us up nicely for next time when we can take this foundation that we're laying and then say, okay, what normal looks like. Let's put some pathology in there, right? Let's put some things in there and let's see what that looks like and see how the gallbladder responds and see kind of how we can then discover that with our ultrasound skills at the bedside for these patients, right? So that's going to be the kind of the overview of today as we go from this patient presentation to a more specific, application in the workup, right? And so from an epidemiologic perspective, gallbladder disease is ubiquitous, right? There's about 20 million cases yearly of cholelithiasis, or 20 million people, in the United States with cholelithiasis every year. So it's very prevalent. It's really hard to go, maybe you can go a day without seeing it in the department, but it's hard to go a week or a month without seeing someone with cholelithiasis, symptomatic cholelithiasis in the ED. It afflicts men and women. Both. There seems to be a slight preponderance towards women, in biliary disease. And one of the things that I've particularly found in my clinical practice is, people who are, postpartum, not like immediately postpartum, but they've had, one or multiple children, females who have had one or multiple children tend to have a little bit more biliary disease than maybe their male counterparts of a similar age. And so there's something involved in that process that's going to be a risk factor here. About 15 to 25% of people who have gallstones will become symptomatic, meaning they'll have some degree of pain as a result of those gallstones causing obstructions in the gallbladder. And about 20% of people will develop cholecystitis, right? So actually full-on inflammation of the gallbladder to the point where it needs to be managed surgically, right? So that's a little bit about biliary disease, right? The mainstay of our diagnosis, right? There's a whole bunch of ways of getting at it, and we can look at studies about CT versus ultrasound and HIDA and MRCP and all these different tests. But the mainstay, at least the initial workup of biliary disease, whether it's you doing it or whether it's radiology doing it, is ultrasound, right? And it's largely because it is simple, it's pretty easy, it's It's non-invasive. It doesn't involve radiation. So we can do this, very ubiquitously in our patient population to really screen, okay, who has cholelithiasis, who might have cholecystitis, and start really narrowing into this population that's going to be, like, hey, we need to keep searching for other medical causes, or, hey, we have something that may need the attention of a surgeon right now. So ultrasound is going to be kind of the mainstay of our diagnosis and kind of where we're going to spend our time. And then if you think historically, it's something obviously we're going to talk about us doing it at the bedside. It's something that we discovered in the emergency department. Is like, hey, because we're doing so much of this, because we're looking for a few simple things, maybe this is something that we in the ED can take the first crack at doing the screening test to see, is there evidence of cholelithiasis, cholecystitis that would either prompt us to say, I can get a surgeon on board now, or I need to do further imaging to kind of further work up. Something looks funny and I need to work this up a little bit more and see kind of what else is going on. And now, because I've done my screening test, I can be a little bit more focused with my follow-on imaging tests, as opposed to very shotgunned, if I don't have that prior knowledge about what's going on, in this patient with my ultrasound. So that's kind of where we're going. To give you a little bit of support or credibility to this, hepatobiliary ultrasound is one of the core modalities that ACEP, the American College of Emergency Physicians, recognizes as an acceptable use of bedside ultrasound, right? So this document is the main document that ACEP, supports, in terms of how you do bedside ultrasound, how you set up the program, how you run it, and then the core modalities. And then obviously there's been over the years a lot of research and a lot of development to additional modalities, but one of the core modalities, one of the original modalities of bedside ultrasound from a diagnostic standpoint is this hepatobiliary ultrasound. And they say here it's, because it is kind of this ubiquitous thing, right? It's portable. There's no ionizing radiation, and the test characteristics are actually really good for ultrasound in general. And then the subsequent studies have shown that ED physicians are pretty decent at doing this ultrasound as well to get to to a very, very accurate diagnosis for these patients. And so that's kind of the support. That's the what gives us the credibility to be able to do this as we pursue this. And I know I've said in this forum as well as at the bedside and in previous times, ultrasound is a great test, right? One of the flaws of ultrasound is that it's only as good as the person who's willing to act on it, right? And so when I have something that I can do a procedure on, and I do the ultrasound to decide if I need to do that procedure, right? Site or abscess drainage, something like that. It's a great test, right? It can help me make decisions. Here, the problem that we have is we're doing a test, right? And then we're asking someone else to do a procedure, and they need to trust that. And so what I've seen develop over the course of my career is that originally, we would say, hey, this is what's going on. And a lot of surgeons would say, that's interesting, but let's get another study to confirm that. Over the years, I've seen kind of that resistance start melting away to the point where a lot of our surgeons will take our word for it, which is great. And that means we got to be good at it. Or use that as grounds to say, hey, let's look at your imaging studies. This is the best one, right? Let's look at your images. Let's make a decision together. And then use this as kind of a way of informing their care. We've been, there's been a couple of research studies that have come out in the last few years, kind of documenting, how well we are compared to radiology doing this. And we've been working on something like that here as well. So it's definitely a field that's grown. The credibility and acceptability of us doing ultrasound in the field of emergency medicine and surgery has definitely grown as well. So with that said, let's dive in and let's talk a little bit about the normal gallbladder. And we'll do it first from a just anatomy standpoint, right? Anatomy, physiology, what does it do? What's it for? Kind of how does it work? And then and where is it, right? And that will help then inform when we look at the ultrasound, what we're seeing and how that makes sense, right? And so the gallbladder itself, right, is basically a reservoir for storing and releasing bile, right? Bile is a fluid, right? It's produced by the liver, kind of gets into the gallbladder via the cystic duct and then the hepatic duct and the cystic duct. It's stored there and then it's released when it's needed, right? So it's stored in the fasting stage of your life, right? You can divide your existence a myriad of different ways but from a hepatologist, hepatobiliary, like GI perspective, it's all viewed in the context of, are you fasted or are you fed, right? Right now, I'm going to have lunch after this, so I'm in the fasted state, right? In a few minutes, I'm going to be in the fed state, right? It's going to change kind of where you are and kind of how things are reacting. So in the fasting state, the gallbladder serves as a reservoir to hold this bile, right? This liquid bile. In the fed state or the prandial state, that is then released, right, to then be used in the digestive process for whatever you just ate, right? The purpose of this biliary substance, right, this bile, is essentially to emulsify the lipids that you eat. So a couple thoughts come to mind here. I remember in biochemistry, and I'm sure you guys remember this as well, at least someone told me, as I was taking, they said, hey, look, the best thing about biochemistry is you can, at the end of the course, take a hamburger and look at it, and you can say, okay, I know how this entire hamburger is digested, right? You can go through the carb pathway, the lipid pathway, the protein pathway, kind of work on how all this is digested, right? And so the lipids, obviously, are not hydrophobic, right? They don't, they kind of isolate off into like these little, lipid things. And so we need to somehow emulsify that, kind of homogenize that, so then we can absorb and then digest, and utilize the lipids that are kind of in the food that we eat. And so example number 2 is when we do our dishes after dinner, right? We may have kind of a lipid-laden dinner, casserole pan or whatever. And as you try to wash that off, you need to somehow emulsify those liquids so that the water coming out of your tap can be more effective at cleaning. And so one of the actions of the dish soap, right, or these dish soap agents, is to kind of do that same emulsification process where you break these little lipid particles up into small things that can then be, homogenized into the greater whole of kind of this hydrophilic kind of substance that's passing through your intestines, right? And so long kind of winded answer to say this is kind of what it's here for, right? The bile itself is composed of a number of different things. The majority of it is water, right? But then you have these bile acids, phospholipids, cholesterol, these various different substances that kind of create this isotonic yet liquids stuff that's going to be aiding in digestion of particularly lipids that you eat, right? Now, from a mechanism of contraction standpoint, obviously we have this reservoir and we need to tell it somehow to dump its stuff into the intestines, right? So it's connected via the cystic duct into the duodenum at the sphincter of Oddi, right? But something needs to tell it to squeeze so that all that stuff can go then into the duodenum to be ready for this bolus of food that's coming from the stomach, the early part of the duodenum kind of coming through to be digested, right? And so there's 2 mechanisms of stimulation for the gallbladder. One's the neural mechanism. This is usually a vagal thing, right? So the vagus nerve fires. It's the rest and digest nerve. So it fires, and among the actions that it's going to do is it's going to tell through the acetylcholine receptors on the gallbladder, hey, time to squeeze, right? And then squirts its stuff out. There's also a hormonal component to this, where when you have this nutrients that's coming through the duodenum, it stimulates the release of the hormone called cholecystokinin, right? CCK then kind of is picked up on these receptors in the gallbladder musculature and cause the gallbladder musculature to contract and then squeeze down. There's also a little bit of a CCK. I gotta make sure I get this right. The CCK also helps stimulate the vagal nerve. I think I got that direction right. Yeah, the CCK, and then the afferent goes up to the dorsal vagal complex, stimulates the vagus nerve to kind of assist in the vagal stimulation as well. So it's kind of a paired response that gets the gallbladder contract, and occurs usually in response to meals, right? You eat something, the gallbladder then contracts, but there's also a little bit of a circadian cycle to this. And I haven't actually done the data to see if the preponderance of our biliary complaints come in the evening compared to in the morning, but that'd be kind of interesting. But when I was doing the research originally for this, they said there's the circadian component to contraction as well. So that's kind of the physiology. If we go to the anatomy, this becomes where it becomes important. Kind of we translate that information into the ultrasound. The gallbladder itself is about 7 to 10 centimeters long, right? So if you translate that into inches, you're looking at about 3 to 5 inches long. And it's in the gallbladder fossa, so right underneath that liver. You kind of lift that liver up, and there's a little bit of a depression there that gallbladder lives in. It holds about 50 cc's of fluid. It's attached to the liver by kind of this fibrous connective tissue. And it's one thing that I remember from my surgical rotation as a medical student is kind of this fibrous stuff that they had to peel away and get at to get that gallbladder off. And I'm going to stop talking about that because I'm not a surgeon, and someone's going to comment on that. But it kind of lives in that area and adjacent to the duodenum. I don't know what just happened to my computer here. Okay, adjacent to the duodenum as things pass through. From an anatomy standpoint, here's just kind of a little bit of an image just to show that it's a, it's this hollow viscous thing. There you see the kind of that corrugated stuff at the end. These are called the spiral valves of Heister. You can sometimes see these on the gallbladder kind of as we scan through them, right? And then here, just kind of another image. You can see the gallbladder kind of terminates into the cystic duct. The cystic duct forms with the hepatic duct to form the common bile duct as it kind of heads over toward the duodenum. And these are different structures that we're going to see. And in that portal triad, right, we'll get to picture in just a sec, the common hepatic duct and common bile duct, there's some vasculature that heads up into the liver, right? And so the portal triad consists of that common bile duct, the portal vein, and the common hepatic artery, right? And so in my medical school, they taught us this is the Dr. Alvin. The duct to the right, artery to the left, and the vein is inferior, is what they told us. So all to say, there's a biliary structure, a arterial structure, and a venous structure, and we'll see that in our ultrasound, right? So as we pivot now to the ultrasound part of this, the first question is, how do we do this, right? Let's take the machine, let's take the patient, let's kind of set up the room. How do we get ourselves started into this scan, right? And so as always, we're going to grab the curvilinear transducer. It's a low frequency transducer. It's got a wide footprint. It's really optimized and designed for the for scanning the abdomen, right? Because it's low frequency, it can penetrate into the abdomen. We can kind of shoot through some of the things that will attenuate sound. It gives us a wide sector view that we can kind of see the gallbladder and the surrounding structures, right? So this is what we're going to go for as we're scanning the patient. Where we go, right? We're going to go kind of inferior to the costal margin, just right of midline. And so the way I like to describe this to people is say, hey, look, we know how to do the fast exam. You can almost get the fast exam started in your sleep if you've done enough of them. You put kind of right upper quadrant, and boom, you're right there, right? You can see the liver and the kidney. If you start there, right, if you find those as your landmarks, the liver is your landmark, the kidney is your landmark, scan anterior, right? So push your probe kind of more towards midline, and the gallbladder is going to be just anterior to the kidney, right? If you are going the other way around, if you find the gallbladder and you're trying to get to the fast exam, just come posterior, right? And you're going to get more towards that kidney. Depending on how deep your costal margin is, you may have to like rotate your probe a little bit just to get through some of those ribs. But really, the best thing is to try to use that liver as the acoustic window. Maybe have the patient take a deep breath to have the diaphragm push the liver below the costal margin so we can get a nice view of that gallbladder, kind of in the right upper quadrant, kind of in this general region as we're scanning patients. Now, from a sonographic standpoint, what's the thing going to look like? And we're going to break this down into a couple different components as we look at these next few images, right? So sonographically speaking, the ultrasound is an anechoic blind-ended, or the gallbladder is an anechoic blind-ended pouch, right? And so if we think about this as the first criteria, this will help us out a lot. And I remember way back when I was a second or third year resident. I think I was a third-year resident. I was scanning someone, and I found an anechoic structure, right, in the right upper quadrant. And as I was scanning, it just kept going and going and going and going and going, right? And I eventually concluded that this is not the gallbladder. This is fluid-filled intestines, right? And that can happen. Oftentimes, the intestines adjacent to the gallbladder are filled with air, and they're going to have that that typical air signature. However, one of the things that you can notice is fluid-filled intestines, and it can trick you a little bit. So as I'm scanning, right, I go to the place, I find something that's fluid-filled, right? Probably, statistically speaking, going to be the gallbladder, but I want to scan towards the fundus, right, which is going to be either probably more inferior on the patient's like external habitus, but I'm going to scan towards that fundus to find that blind-ended pouch, right? It's a little bit cut off in this image, but you're going to see it stops, right? I don't want to see it continue to go. And once I find a blind-ended anechoic pouch, then I know I'm kind of in the right place. And so we put some labels on this thing. The inferior portion of this gallbladder, at least relative to the patient's external anatomy, is usually the fundus, right? The body is kind of is what it is. And then it tapers into the gallbladder neck as you get to the septum, cephalad portion of this gallbladder. Because remember, it kind of hangs upside down in that gallbladder fossa as you're scanning these patients, right? And so it's going to taper down to that neck. And it's really, really important. We'll talk about this next week. Really, really important that you scrutinize not just the fundus, because stones can hang out there, but also that neck, right? And actually, I'm more worried about the neck because, the fundus, that's just stones in the gallbladder. But that stone in the fundus is not causing the patient's symptoms right now. If the patient's symptomatic, there's something going to be there's going to be something probably in the neck that I really need to worry about, or in the ductwork, proximal to that. And so I really want to focus in where it cones down into that very pointed area in that gallbladder neck is kind of where I'm looking. So 7 to 10 centimeters long, is the typical dimensions. I don't typically, try to measure the gallbladder length. I'll measure it. The width is kind of something that I'm worried about, but not typically the length. In my scans, but just to know kind of as a reference point, that's where it is, right? Now, step number 2, once we've found that, once we've kind of scrutinized the fundus, looked at the body, kind of found the neck, is go to look at it in transverse diameter, right? Because we want to see something that's roughly 3-ish centimeters wide, right? You can tolerate up to 4 with a wall that's less than 3 millimeters thick, right? And so here's the transverse. We just turned the probe kind of 90 degrees, probe indicator towards the patient's right, generally speaking, to get this rounded view of the gallbladder in transverse orientation, right? It should just be a decently rounded circle. And I think here's a good time to just take a pause, just to remind everyone, it's always nice when the patient's internal anatomy is consistent with the patient's external anatomy, meaning sagittal is always up and down, transverse is always straight across, right? The reality is the gallbladder doesn't always follow the rules, right? And sometimes it can be at an oblique angle relative to the patient's external anatomy. Sometimes it could be, straight up and down. Sometimes it can be all over the place. And so when you scan the gallbladder, sagittal and transverse are relative to the gallbladder. You try to keep it relative to the patient's external anatomy, but more often than not, your sag is going to be oblique to the patient's external anatomy to get that true elongated gallbladder view. And so you have to play this a little bit. You have to be very careful kind of as you're scanning it, that you're getting the whole length and then looking at it in its width, understanding that it may not follow the rules that you see on the outside. But this is gallbladder and transverse orientation. I really like the transverse orientation as I'm scanning because it gives me a good view. I can scan down to the fundus, see kind of that become, see that fundus kind of end, and then I can scan up to the gallbladder neck. And it's a really great way to follow. It's really easy to follow it in transverse orientation as you're scanning up to the neck to see where it tapers, to see that stone. And it's sometimes easier to see that neck in transverse than it is in long axis. And then the final aspect of the gallbladder sonographic anatomy is that it's connected to the portal triad via the main lobar fissure, right? And so I find as I talk about, orienting myself to the scan, finding landmarks and moving from one landmark to the next landmark. And so the finding the gallbladder, right? Finding the portal vein, the main lobar fissure are kind of these stepwise progression of doing, of working through the landmarks that we have here. So, what I'm saying, what I mean by that is basically here's an example of your gallbladder, right? You can see that it's not labeled here, but you can see the gallbladder. You can see that portal vein that is labeled in this bright white structure in between the two. That's that main lobar fissure of the gallbladder. It's kind of that hyperechoic thing, right? And so it tends to create what we call this exclamation mark sign, right? You can see that kind of that sideways exclamation mark. So I'll scan through the gallbladder, kind of twist until I can find the portal, connect that to the portal via the main lobar fissure. And that walks me from my gallbladder to my portal vein. And then that sets me up very nicely for the next structure we're looking for, which is the common bile duct. And for beginners, this is the most frustrating part of the gallbladder ultrasound because it's really the hard part to see, right? I remember struggling for many, many years as I was scanning through gallbladders, like I can't find the CBD. I can find the gallbladder, I can follow that, but I cannot for the life of me find the CBD. And when I started working that progression of, I found the gallbladder, I went and used the gallbladder to help me find the portal vein. Once I found the portal vein, I'm in the neighborhood where I need to go, and then the CBD is kind of right there. So this common bile duct is generally formed by the convergence of the hepatic duct and the cystic duct. And it generally travels anterior to that portal vein. So if you can get on that portal vein and see the portal vein kind of at that main lobar fissure area, your CBD is not far away. And now it's just little probe manipulations to find it, right? It generally tends to be about 5 to 6 millimeters at max diameter, right? It can be less than that. But it can be bigger than that under a couple different conditions, right? Number one is pathologic conditions. So if you obstruct it, it can get big. right? That's the one thing we're worried about. Number two, if you take the gallbladder out, the CBD tends to get a little bit bigger, right? You can, see it enlarged there. Number three is as we get older, right, the CBD can sometimes, the diameter can be, the upper limits of the acceptable diameter can be expanded a little bit, right? So we'll allow for 1 millimeter of CBD thickness for every decade of life after about 50 or 60. So if you have a 90-year-old person who has a gallbladder that's like 7 millimeters, you got to look back at their old stuff, look at it in context, but you can see that, and it not be pathologic. So those are the three different reasons why you might have a dilated common bile duct. But if you want to look at some pictures, here we go. So we found the portal vein. Once you find that, turn your probe towards that 10 o'clock position, right? Just subtly, and usually the CBD will just pop right out as that train track that's right above that portal vein. You can see here, it's labeled, but you can see kind of that little elongated tube just above the portal vein. That's the common bile duct. So again, just to reiterate, you go onto the gallbladder, get long axis of the gallbladder, follow that down to the neck, scoot the neck over to the portal vein because it's connected to the gallbladder neck at the main lobar fissure. Once you're on the portal vein, twist towards 10 o'clock, right? And then your CBD should be right about there. You'll scan past it and you'll probably see it pop out, and then boom, there's your common bile duct. So that's how you walk from one to the next, right? There's a couple other things you can do to help bring that out. Throw some color Doppler on it. The vascular structures nearby should light up and the CBD shouldn't. So that can be helpful. But obviously if you follow the anatomy, that works too. Here's an example of a slightly enlarged 7.6 millimeter common bile duct. You threw some color on there. You see there's no color. Compared with the vasculature next to it. And actually the circle just deep to that is going to be the portal vein. We're seeing it on face, so because of some Doppler mathematics, we're not seeing a Doppler color there, but you see the hepatic artery just next to it, right? So this is just an example of that CBD. A couple normal anatomic variants that you're going to run across. There's something called the Hartmann's pouch, right? And so it's basically this little folding of the gallbladder somewhere in the middle of the body. There's a little bit of a septum there that you may see. This is normal, right? Something that you're going to run across if you scan gallbladders. And then one of my favorites is called the Phrygian cap, right? And it has a historical reference. It's this cap that was seen, you see it in different historical, places, but, you think about the French Revolution kind of era, it's a hat that was worn kind of in that era where you have this hat and then the little top just kind of folds over. You can imagine like someone's got like an enlarged beanie type hat and that folds over the top now, be kind of like a Phrygian cap. And so it's basically a fold at the distal portion of the gallbladder, the distal fundus. It's called a Phrygian cap. So with that being said, let's talk briefly about a few pitfalls, and then we'll kind of wrap things up today. Things that may make it hard to scan the gallbladder, and this is one of the critiques that I have, is it's just not the easiest scan to do. Once you do it, it's pretty straightforward, but it's certainly technically not the easiest one that we can do. Right? There's some technical difficulties that are there. So one of the pitfalls is if the thing's just contracted, right, or if you have a difficult window to scan through. If you have a particularly fatty liver or, an obese patient, that fatty attenuation can make it difficult to see. And then if you have gallbladder pathology, that can kind of obscure things and make it look a little bit funny. And we'll talk about that a little bit more next time. But here's an example of a contracted gallbladder. So if the patient comes in and say they got right upper quadrant pain, but they just ate a big hamburger, you may not see this ginormous gallbladder. You may see something small like this. Now, you could also surmise if you see this, you don't see stones in there. That's for another time. But it can be challenging to see the gallbladder, particularly if the thing's contracted. The other thing that I found, just kind of a little pearl that wasn't listed there, is just make sure the patient still has a gallbladder. I've done this a couple times in my career where I went to scan a gallbladder, couldn't find it, and then, asking some more pointed questions, it turns out the patient actually had a cholecystectomy. They just didn't remember the terminology that they needed to use to communicate with that to me originally, right? And so if they don't have a gallbladder, you're going to have a hard time finding the gallbladder. So just be aware of that. But this is an example of a contracted gallbladder. If we turn in transverse axis, you can see the arrow is pointing towards this little target sign, which is very, very challenging to see in this context. But this is a contracted gallbladder, and like you can say, like I said, it can make it very, very hard to identify the structure that you're looking for. Secondly, is the rib shadows, the surrounding structures. Here's an example where you can just see that rib is right in the way. The gallbladder is immediately underneath it, so there's no way I'm going to really see kind of clearly what's going on in the gallbladder, at least in this window. And so the thing to do here is if you can't see what you need to do, move, right? If you're in a crowd and you're watching someone, on a stage or something like that, if you're at a concert and watching someone on the concert and someone tall is in front of you, how do you see the person on the stage? You move, right? You look around them. It's the same thing with the ultrasound here. Either you move the probe, kind of go down and look up, go up and look down, twist to get between the ribs, things like that, or you have the patient move their gallbladder, right? And the way you do that is just say, hey, take a deep breath, hold that deep breath, and that pushes that gallbladder fossa below the costal margin most of the time, and you get a better view. Now, you have to tell them to take a breath or they don't like it. But you can kind of do this exam in different chunks where you can kind of get these different windows, as you're working and coordinating with your patient. The other one that I really, really like is just repositioning the patient, right? And this is one of the things when I go in, patients are always supine on their back. Go in, find the try to find the gallbladder with the ultrasound, scan through it. If I see what I see, or if I see what I need, great. I'm good to go. I'm off to the races. If I don't see what I need right away, the first thing I'll do is have the patient roll to their left side, right? And what this does is basically moves the gallbladder, but in a different way, right? We talked about breathing to move it. Now this one is using gravity to move it. So you roll the patient, the gallbladder kind of flops down a little bit more towards the midline of the patient, but since they're on the left side, it also pulls it out from underneath that costal margin and gives you a little bit more of a window. If you push your probe a little bit more medially, you can kind of scoot back and see that gallbladder as you're scanning that patient, right? So repositioning the patient either by having them breathe or having them roll to the left side will do wonders at helping you find the gallbladder more frequently as you're scanning. A couple other things you can do in addition to these positional stuff is obviously make sure you're in the right preset, so all that stuff's ready, but you can toggle on and off your harmonic imaging to see if you can kind of play with some of the artifacts there, or change the frequency. If you're having a hard time kind of punching through getting some of the deeper structures, try lowering your frequency to see if that will allow you to kind of get into some of those deeper structures to see kind of what's going on inside the gallbladder. So with that said, we're going to kind of wrap things up here. What we talked about just by brief review today is kind of the scope of biliary disease, kind of why we're doing this, and then talked a little bit about the normal anatomy and physiology of the gallbladder, how it contracts, what causes it to contract, where it is, what are the structures around it that we're going to be seeing. And then we applied that with to the ultrasound, or actually applied ultrasound to that to then see how we can visualize what we looked at, what we knew to be true from an anatomic standpoint. We saw how that works with the gallbladder ultrasound, and kind of how we can get the long and short axis, kind of some of our measurements, what it's going to look like on the ultrasound. So that's today. Next time we meet, which will be in 2 weeks, we're going to discuss abnormals, right? This is the normal gallbladder. Next time we're going to talk about the abnormal stuff, the sonographic appearance of cholelithiasis, gallstones, right? The sonographic appearance of cholecystitis. What does the inflammation of the stone-filled gallbladder look like? And then we'll look at some of the literature for the use of ultrasound by ED physicians at the bedside, and how we compare to the gold standard of radiology as we're scanning our patients, to really lend support to the fact that we aren't trying to supplant radiology completely, but we're trying to use ultrasound as this screening tool to help us better identify which patients need more comprehensive imaging, or which ones we screen into kind of another care pathway. And so hopefully you guys can join us for next time. But as we wrap up anything, we'll see. Does anyone have any questions or comments regarding gallbladder ultrasound? Alrighty. Well, let's wrap things up here. Thank you guys for joining us today. I'll look forward to seeing you guys again next time. As always, all these lectures are recorded. We put them up on the YouTube channel so you can go back and review them. So if you want to go see some of the cardiac stuff, go back and look there. We have this one. We have some other the upcoming gallbladder lecture next week, and we can go look back at some of the ones we've done in years past. So all that's there. While you're there, hit that subscribe button, the notification bell, so you know when we put more videos up. And for those of you guys who are here in real time, who are watching this right now, you can join us again on the same time, same Zoom link in 2 weeks, and we'll talk about the abnormal gallbladder. So have a good week. Happy scanning. We'll see you next time. Bye.